Greetings, everyone. Welcome to the 160th session of the online Optom Learning Series, OOLS. And to start this year, for today's session, we have with us Dr. Shonraj Ballae Ganeshrao. Dr. Shonraj is an associate professor and also the head of optometry department of the Manipal College of Health Professions, Manipal Academy of Higher Education, which is the MAHE. Dr. Shonraj completed his bachelor's and master's degree in optometry from the Elite School of Optometry in Chennai, and then went ahead and did his PhD in vision science from the University of Melbourne, Australia. His areas of interest and specializations are visual field, the structural functional relationship in glaucoma, the changes what happens in the visual field with the progression of glaucoma related to eye movements as well. Currently, Dr. Shonraj is heading the Visual Function Lab at the Department of Optometry where he works, and his research work is generously supported by extramural grants from the Department of Science and Technology and also the Science and Engineering Research Board. And Dr. Shonraj today is going to take us through his, his expertise, perimetry, what are the test algorithms and how we should be careful in terms of clinical practice. So welcome Dr. Shonraj onto our platform, and let me just leave the screen time to you.
Thanks for Kadeem. So thanks for this introduction, and I wish you everyone a very happy new year. I'm going to talk about perimetric test algorithms, and I'll bet you you have heard about. So far, whenever we talk about perimetry or we talk about the visual fields, we talk about what is Humphrey, what is octopus, what is 24-2 grid, what is the false positives, false negatives, what is mean by mean deviation, total deviation, how to look for the defect and all. But today I'm not going to touch any of this. In fact, I'm not even going to show you a single visual field report today. Today, I'm going to talk a very basic, very fundamental. I'm going to talk about this black box called full threshold, CETA, and Bayesian-based algorithm. So we all assume that, so there is some algorithm, so I run this algorithm, this is what the output is going to be. But how this black box, how this algorithm works, no one knows, or we don't know, we don't have much clarity on how this algorithm works. And that's being my main area of interest. So I will be concentrating on that a bit more today in my talk. Okay, so this talk, let's say, today I will be talking about this commercially available test algorithms. What are the different commercially available test algorithms are there, and how this commercially available test algorithm works, how it really works. Then we will be talking about what are the pitfalls in this commercially available test algorithm. So I'm going to use this words algorithms and strategies interchangeably, so kindly bear with me. So I'm going to talk about what are the different pitfalls of this commercially available test algorithms. And then I will give a little bit overview about what are the new things that are coming up in the research field. So as a clinician, you also keep yourself updated on this bit. Okay, so let's first talk about this commercially available test algorithms. Now, before I go into that, let's look at the history of perimetry. Now, this perimetry basically, as you guys know, started way back in the Helmholtz, way back in 1850, where they started with simple confrontation technique and then simple arc perimetry. There was a major big breakthrough in the perimetry where they started with this manual perimetry back in the 1950s with Goldman, and with Goldman started this manual kinetic perimetric method, which was a standard for a pretty long time. And then somewhere after the invention of this computers, we have this automated static perimetry. So we moved from the kinetic perimetry to a static perimetry. I guess you know the difference. I'm not going in detail about it. And then from there, we had this automated static perimetry. And for with automated static perimetries, you need to have this test strategies which can automatically detect your threshold values. And if you look at the automatic static perimetric growth, we had so many different branches in that. So we had this frequency doubling perimetry, short wavelength automatic perimetry. And in the terms of algorithm wise, we have the theta, progressor, scope. Sorry, these are the progression analysis to be honest. So we had top, theta, scope, gate, BFI, and things like that. So many newer algorithms developed, and the recent one being the theta faster. Theta faster, it's called, right? So the newer one being called like theta faster, which is recently incorporated in the Humphrey machines. Now, what is perimetry? In what we do in this static automated perimetry? What we really do? Well, in perimetry, we are trying to measure what is that minimum quantity of the stimulus that can be detected. In other words, we are looking at what is the minimum light intensity that can be detected against a uniformly lit background. So it can be defined as differential light thresholds or differential light sensitivities. So DLS is defined as change in this minimum light intensity against its background, where your del L is the small increment in that, or the small change in that light intensity against your background intensity. So we are trying to find out this differential light sensitivity or differential light thresholds at different retinal eccentricity or different eccentricities in your visual fields. Now, to estimate this, to accurately measure this DLS or differential light sensitivities at different locations in your visual fields, you need minimum of 140 to 110 stimulus presentations. You need minimum of 140 to 210 of stimulus presentations. Now, as you know, we do a minimum of 54 locations in perimetry. That is 24-2 grid has 54 locations. So if you multiply that 54 into 140, so you do the math. So that many number of stimulus presentation is required for you to accurately measure the differential luminance sensitivity values at different locations in your visual field. And that would take really more than 2 hours of patient testing. So one visual field test for one eye would take 2 hours if you really want to accurately map this or accurately measure the sensitivity values at different locations. So in clinic, we don't do that. We cannot afford to do that. And in reality, you can do this in lab. There are people who have done it in laboratory. I have done this for my PhD, 2 hours of visual field testings for one eye. So you give a break, you ask them to do a perimetry for 5 minutes, you give them a break, they take a break and then do it again and then take a break. So it is probably possible at laboratory, even at laboratory settings, it becomes difficult. But in clinics, of course, it's impossible. So we need to really measure this quickly at 54 locations, these differential light stimulus sensitivity values. And that's where this test strategies comes in. So we overcome this by using what we called as adaptive psychophysical test procedures. So we use this adaptive psychophysical test procedure to shorten the test time and to get the threshold values very quickly. Now, if you look at what are the adaptive, so this is clear, I guess. So first issue is you want to measure this differential light stimulus sensitivities at different locations in your visual fields. And if you really want to measure carefully this sensitivity values accurately at different locations, that takes really long time. So we need to somehow cut short it and then measure this quickly and use this techniques called adaptive psychophysical test procedures to really shut down the time. Okay. Now, what are they? What are these test strategies? So, now, if you take these adaptive test strategies or adaptive psychophysical test strategies, they can be broadly classified into three types. Number one is staircase based, and under your staircase based, you have your full threshold, which is implemented in Humphrey field analyzer as an example, and also the dynamic strategy, which is implemented in the octopus perimetry as an example. The second is the Bayesian based. The Bayesian based, you have an ZIPI, which is ZIPI ZEST, which is the full form of the ZEST is ZIPI estimation by sequential testing, which is implemented in the mid-mount perimeter, and Quest, which is basically not implemented in any of the perimetric test procedures. But we still do use this as an adaptive psychophysical test procedures for many of the psychophysical tests. And finally, you have this a combination of this both staircase and the Bayesian-based procedures. And the most commonest of all this is the SITA, which is Swedish interactive test algorithms, and which is very popular, implemented in the Humphrey field analysis. Okay, now let's look each one. Let me try to explain how each one works. Okay, so let's first look at the staircase. Now the staircase test procedures works something like this. For whenever I say an adaptive psychophysical test procedures, that means you show a stimulus. Based upon the response, the next stimulus presentation would be based upon the previous stimulus presentation response. So if you look at this equation, the equation looks a little bit complicated, but it is not at all complicated. So the intensity for n plus 1th trial is based upon the intensity of the previous trial plus whatever the step size you have decided. For example, if you decide that you want to use a 4 dB step size or a 2 dB step size, whatever the step size you have decided, multiplied by the whether what response you give. So for example, if you give a positive response, then you add the step sizes. If you give the negative response, then you decrease the step sizes. Basically, that's what this equation means, right? Now, if you do not understand this equation, let's put it in an example and then see. Now, here is how a full threshold, a real full threshold in Humphrey field analyzer works. And now, full threshold is it's widely been tested, and then many people have studied this, and we know exactly how it works. Now the full threshold, let's take an example. Let's say we take this location, which is marked as 1 here. So this is fovea. This is a 24-2 grid, what you are looking at. This is the blind spot. This is the nasal locations. And each location is 6 degrees apart in this 24-2 grid. Now let's take this particular location, which is I am just highlighting here. Now let's say for that particular location, for the first stimulus presentation, so what I have here, I have a stimulus presentation sequence in the x-axis and the intensity in the y-axis. Okay, so let's for the first stimulus presentation, let's say I showed a 25 decibel target. Now let's say the patient said, no, I didn't see the stimulus. So the filled circles here means no, unfilled circles here means yes. So you showed a 24 decibel target and the patient didn't respond to that. So the patient obviously didn't see the target. Then what do? You decrease the stimulus intensity by some fixed step sizes. In full threshold, you decrease first by 4 decibel. So you decrease by 4 decibel and see what is the response here. Let's say the patient still said no. Then you still decrease by for the third stimulus presentation. Again, you decrease by 4 decibel and then see what is the response. Still the patient said no. Again, you decrease that by 4 decibel. See where is the response. Still the patient said no. Again, you decrease again by 4 decibel. Now let's say the patient said yes. The moment the patient says yes, then what you do is you are going in one particular direction. Now suddenly you are going in the other direction. So now this is called a reversal of responses. So once you notice this reversal of responses, you decrease the step size, instead of going by 4 decibel, you increase the stimulus intensity by 2 decibel and see what is the response. Let's say the patient said yes again, which means you keep going in the same direction. Now you said the patient no, so there is a reversal of response happening here. The moment you reversal of response happened here, you go in the other direction and then see what is the response here. So as you can see, the initial step size is 4. The initial step size is 4. Once you have one reversal, the step size become 2 step sizes, and then another reversal it become 2 step sizes. So the full threshold is also sometimes called as 4-2-2 strategy. Okay, 4-2-2 strategy. So it uses the 4-2-2 step sizes to look at your threshold value. In case of full threshold, the last seen stimulus intensity is taken as the threshold value. For example, in this case, or the last scene is here. Sorry, this is not seen. The last scene is here, which would be somewhere around, let's say somewhere around 11 decibel. So the 11 decibel is taken as the threshold value for this particular location. The once it determines the location here. The first thing the full threshold does is it determines the thresholds at these locations which are marked at 1. Now, once these locations were tested out, then the second location starts testing. Now, how it starts? For locations which are marked 1, the staircase begins with 25 decibel. For the locations which are marked 2, the starting point of the staircase would be the threshold values obtained from the 1 locations. For example, at one location, let's say I got a threshold value of 11 decibel, then 11 decibel is taken as the starting point of a staircase for the locations marked at 2. Similarly, for locations marked at 3, the starting point of the staircase is taken from the locations marked 2. Similarly, for the locations marked 4, the starting point will be taken from here. So it uses this pattern, and we call this pattern as a growth pattern to estimate your threshold values. So it runs a simple staircase, 4-2 staircase, to establish your threshold values. Now this is similar, the dynamic strategy also uses a much similar approach. Instead of using a 4-2-2 strategy, it uses a 4-2-1 strategy. What does that mean? For it keep on going in a 4 decibel step until it notices the first reversal, and notices the first reversal, it goes by another further by 1 step going. The next reversals, it goes down by 1 step instead of going by 2 steps. So it is called 4-2-1 strategy. So the dynamic strategy uses a 4-2-1 strategy, whereas the full threshold uses a 4-2-2 strategy. All right, so I think this is clear. So this is very simple. So full threshold works by a very simple concept using adaptive staircase, and pretty easy to understand. Now, next one, let me try to explain how the Bayesian-based test procedure works. And now all the newer versions are based on Bayesian-based. But the Bayesian-based test procedure works using this using a principle called Bayes' theorem. And if you want to look at the mathematics, this is how it works. And this is a little bit complicated to explain compared to your full threshold equation. So I'm not going to explain this equation, but let me try to show this how this works by some examples here. Now, the Bayesian-based test procedures. So I have taken ZEST test procedure. Just here is a Z estimation by sequential testing, which is a Bayesian-based test. So I'm going to explain how the ZEST works. So from that works. So the ZEST usually starts with some prior probability mass function. Okay, so let's say here what 0 to 40, and what you have it is the probability of obtaining the sensitivity values. Now, how do you get this curve? You test it on probability of this particular population getting a threshold value of 10. So you get this, and then you plot the histograms, and you join the middle of the histograms. Function is called as prior probability mass function. So all the test perimetry, all the test locations will have this prior probability mass function as the starting point. Now you take this prior probability mass function, and then you present the mean of this prior probability mass function. So if you can calculate the mean of this prior probability mass function, it comes somewhere around 15 decibels, and then you present this 15 decibel target to the patient, and then see what is the response. Yes. Then what you do is you multiply that with an yes likelihood function like this. And if the patient said no, then you multiply this prior probability function with a no likelihood function like this. Okay, so depending upon the patient response, you multiply with, am I still connected? I think I'm still connected. Okay, based upon your responses, based upon, so we probability mass function. So this location, what is the probability of me getting some threshold value is obtained from the populations. Second thing what it does is, it takes the mean of this prior probability mass function and presents this as a stimulus to the patients. So depending upon the patient's response, the likelihood function, the yes likelihood function or no likelihood function is multiplied to this prior probability mass function to get what we call it as the posterior probability mass function. If you showed a 15 decibel target, this posterior probability mass function. If they said yes, then you would get a curve like this. If you would have said no, then you would have got a curve like this. Now, what happened is this posterior probability mass function will act as a prior for the next stimulus presentation. So we start something like this, and then that would act like a prior. Then let's say you take the mean and then you present the mean 20 decibel target you present to the patient. Let's say the patient said no to it, and then you multiply this, and then you end up like this. Then you this become the prior, and you start the mean. Let's say you show some stimulus here, and based upon this stimulus response, you multiply this with this likelihood function to get something like this, and then you keep on going like this, and you keep on going like this until your posterior probability function becomes really narrow. Now you have narrowed down where exactly your threshold values is going to be. You started with something big, and now you ended up with something really narrow. Now the mean of this is taken as the based test procedure works. You start with a huge assumption, and based upon your responses, you narrow down, and then you narrow down where exactly your threshold, and you take the mean of this. Okay, so that's how the Bayesian-based works. So it's not as simple as your staircase. Your step sizes are not fixed. The step sizes are basically defined, or the next stimulus presentations are basically defined based upon what is the posterior probabilities you want to obtain on your previous prior. The mean of this prior is taken as the threshold value. So that is how the Bayesian-based test procedure works. Okay, so all good. Now what? Now how this CETA works, that's where I'm more interested in. Okay, now the CETA, like I told you, is a combination of a Bayesian-based and a staircase-based test procedure. Now, the exact working principle of CETA, no one knows because it's a proprietary, right? And we don't know exactly how it works. But we do have a fair idea how this works. Now we think it starts with this prior probability mass function, much similar like your ZEST test procedure. So it starts with this prior probability mass function, but the step sizes is followed as seen in your staircase. The step sizes is seen as followed in the staircases. So it follows a staircase step size stimulus presentation sequence, but for every sequence, for every questions, like it is given as question 1, question 10 like this, for every questions or for every presentations, this probability mass function is constantly altered, and then it stops the presentation or it terminates the stimulus, test procedure when this probability mass function becomes really narrower. So once it becomes narrow, again the mean of this probability mass function is taken as the threshold value in CETA. So like I told you, CETA is a combination of both. It uses this constantly alters this probability mass function for every stimulus presentation, but the stimulus presentation sequence goes like a full threshold. And much similar like a full thresholds, CETA also uses the growth pattern for the stimulus starting point in your CETA. So it also uses this growth pattern to calculate the threshold values. So this is very briefly about how the Bayesian-based test procedure and CETA works. Believe me, Bayesian-based test procedures are math interns, and I tried to not to use any statistics and try to give it by example. So this is how it basically works. Now, In addition to that, CETA, we know that CETA test procedures, be it CETA standard or CETA faster, is a little bit, faster than your full thresholds. So how does it improve the speed is the question. It improves us the speed by doing three things. One, by using this Bayesian-based approach. Number one, which is just I explained to you. Number two, by not using the catch trials for the false positives. I'll explain this what it means. And number three, by using an adaptive interstimulus interval. Again, I will explain this in the subsequent slides. Okay, let's look at this one first by using adaptive interstimulus interval. Okay, now let's take a perimetric stimulus. This is how your time flows in your x-axis. And let's say you showed a stimulus for 200 milliseconds, and then you wait for 100 milliseconds for stimulus response, and then you show the next stimulus for another 200 milliseconds, and then you wait for 1000 milliseconds, and you wait for another 1000 milliseconds, and then you show another stimulus. That you keep on going, right? Now, let's say for first few stimulus presentations, you notice where is the patient is giving the response. So, like for example, I show a stimulus for 200 milliseconds, and I wait for 100,000 milliseconds, and see when is the patient is, and then I show the next stimulus presentation. Now, let's say the patient is responding at 800 milliseconds. This particular patient is responding at 800 milliseconds. So I responded one at 800 milliseconds, 800 milliseconds, 800 milliseconds. Then I know this patient is responding at 800 milliseconds. So what I do is, instead of me waiting for 1000 milliseconds for the next stimulus presentation, let me shorten this window by 800 milliseconds. So it sees what is this your stimulus, at what point you are responding to the stimulus. So based upon your stimulus reaction times, the interstimulus duration is narrowed. For example, if you see someone, let's say they are responding only at 600 milliseconds, 600 milliseconds, 600 milliseconds, then this was kept at 700 or 600 milliseconds or something like that. So the interstimulus duration will be altered based upon your responses. So that's how it reduces the test duration. And the other thing it does is, we all know what is a false positive is. So false positives uses a catch trial. You know what is a false positive is. I'm not going to explain to you, but briefly it is like you wait for a brief period of time and see whether the patient is responding or not. In other words, false positives are responses when there is no stimulus is presented. Okay, so what you have to do, you basically have to wait for some time, just mimic the sound and see where is this, whether you are responding or not. But usually your CETA doesn't does that. What it does is, immediately after you present the stimulus, for the next 50 milliseconds, your brain takes time for you to respond. So you cannot respond to the stimulus within 50 milliseconds. But let's say if you responded within this 50 milliseconds, then there is no way possible that you have already processed the stimulus and then responded to the stimulus. So it must have been a false positive response. So the CETA thinks if you responded within 50 milliseconds of the stimulus presentations, then that must be a false positive response, because it is practically impossible for you to respond within 15 milliseconds of your stimulus presentation. So those presentations which are false within the 50 milliseconds of your immediately after your stimulus presentations are taken as the false positive responses in the CETA. So this is how your CETA becomes slightly faster when it compares to your full thresholds. Okay, so what have we seen now? We have seen how this commercially available test strategies are working. Now, what are the pitfalls? What are the problems with this commercially available test strategies? Well, I told you to really want to accurately measure this differential light sensitivities, you need to have more than 2 hours of patient testing. So you need to show many more stimulus in each locations to get accurate values. But as you know, in perimetry, we cannot afford to do that. So we are going to measure this differential luminous sensitivities pretty quickly within like 4 to 5 minutes. So there is always this trade-off of time versus accuracy. Since we decided to do it quickly, whatever we are measuring is neither accurate nor precise. Okay. Now, if you look at the test-retest variability of your theta and full thresholds, it is so huge. What it means, let's try to understand this graph a little bit. And this is very important for you to understand this graph. So what they did in this particular study is they measured this stimulus, they measured the perimetry once, and they asked them to come again some other day, within a week's time, and then they asked them to do the perimetry one more time. Now what happened is, say this. So let's say in this particular location, so they've got a threshold value of 8 decibel. Okay, so let's say they got a threshold value of 8 decibel. Then when they ask them to come and do the perimetric test again within a week's time or so, the perimetric for the same location, the threshold values were ranged from 0 decibel to 24 decibel. Okay, it can range anywhere from 0 decibel to 24 decibel. That means you really don't know whether this patient is actually has progressed or is it just the variability you are getting. So this is the test-retest intervals for your theta and theta fast. Okay, and I will tell you what, for full thresholds, the boxes are actually full thresholds here, but for the full thresholds, the test-retest range is also so huge, which means this is none of these test algorithms are precise enough for you to accurately calculate the progressions. Okay, so keep in mind, none of the perimetric test strategies are accurate nor precise. Okay, so that's the reason why clinicians, if they think there is a progression in Humphrey Fields analyzer or any visual field test, they will try to repeat it one more time before prescribing a drug or before doing a surgery. A good clinician would do 2 or 3 times perimetry to confirm the real diagnosis or real progression, and then prescribe the medications or take a call about the surgery. So keep in mind, none of your perimetric test strategies are neither precise nor accurate. Now there is another issue. So one of the issues we talked about is this time versus accuracy. Since we chose to do it as time, it is not neither accurate nor precise. The other issue is the sampling issue. Now remember this, your 24-2 grid are sampled every 6 degrees apart. Now, there is a particular study where they sampled between these 2 6-degree points. So they measured between these 6-degree points. They measured what is your visual field between that 6-degree space, and they found a tiny scotomas lying between this 6-degree space. Okay, so you might miss this tiny scotomas within this 6-degree space because you are really not checking the visual fields there. So there are 2 issues. One is the sampling issues. This means that it is possible to miss the small tiny scotomas that you see in the perimetry. The second issue is this, that whatever you measure using the perimetry is not accurate and neither precise. So with this keeping in mind, the newer algorithms, whichever is or the perimetrists are working on, or people who are in a perimetric research like me, are working towards to improve these 2 main issues. That is, how can I make it accurate and precise, and how can I make it to pick up small scotomas. So there are many newer algorithms that has been developed. None of these are being implemented in the commercially available test algorithms, unfortunately, but these are all in the research stage. Many of them are published long back. There are a couple of them published by me. One of them is CMU and then defect-based algorithms, and a couple of them are published. A couple of them are co-authored as well in these publications. Now, let me just explain the ones which I have first authored it. So let me very briefly tell you how the CMU works. Now, you all know the CMU, the full form of the CMU is structural estimation of minimum uncertainty. I just told you how a Bayesian-based test procedure works, and CMU is a Bayesian-based test procedures. So it works based on the concept of Bayesian-based algorithms. But however, what it does is the prior of this. So I told you the prior of the structural-based prior of Bayesian-based test algorithms is based upon the normal population. So instead of you taking this as from the normal population, can I take this from the structural information? If you do an OCT, let's say you get an OCT and then let's say you see an inferior arcuate defect, then you are pretty sure that the superior part of the visual field is going to be affected. So can I alter the prior probability mass function of a Bayesian-based algorithm based upon the structural values? So that's how this perimetric test procedure works, and we publish this in OBS. So it uses a complicated decision tree modeling to narrow down the priors. I'm not going to explain this, is completely out of the scope of this talk. So it uses a complicated method to identify this, and then what we found out is this. Now what you have this boxes is full thresholds, your test retest variability, and whatever that is marked in red is this CMU test algorithms accuracy or variability, to be honest. So if you look at this, the CMU algorithms variability is a little bit lesser compared to the two threshold algorithms variability. Now, next sampling thing I'm going to talk about is the defect-based sampling thing, which is trying to tackle that. So to pick up the small scotoma issue, again the same idea that instead of me using, we know that if you find inferior arcuate defect in the OCT, we know for pretty sure that there will be a superior arcuate defect in the visual fields. So instead of me testing all the points here, which is a waste of time, I can rearrange these points. I can take some of these points and then put it inside the scotoma region so that I can accurately estimate the scotoma. So again, we use some kind of a complicated decision modeling, and then we model it based upon their RNFL thickness around your peripapillary RNFL thickness. And then based upon where this defect is, we are rearranged the points in such a way that, as you can see here, the points were more put it in the top of the visual field. So whatever that is there in the red color boxes, so it samples more in the superior region and it samples very little in the inferior region. And using this method, we compare it with the different grids. We compare it with the octopus grids and the 24-dash grids. In all the grids, the number of points is better with your defect-based samples. So the defect-based samples picks up the scotoma, fine scotomas compared to the other grids. So to summarize, there are the perimetric test algorithms are not always good or are not always gold standard. There is an issue with the perimetric test algorithms. The main two issues, there are many issues, but I'm just going to concentrate on this. Main two issues is that the test retest variability, that is, it is not precise to give the same threshold values if you measure it multiple number of times. And the second main issue is the sampling issues. And there are many research going on, and this, as we speak, there are one of my PhD student is working on a newer algorithm and trying to find out what is the test retest variability in the newer test algorithm. So there are researches going on, but for you as a clinician, please keep in mind that these perimetric test algorithms, whatever you have, is not accurate and not precise, and it still have a problem of picking up smaller scotomas based upon the grids which you are using. And I also give you a little bit overview about how this perimetric test algorithms works. With that, I will stop the talk. Before I acknowledge my lab members, and I have put only my PhD students here and my research scholars. One of my research scholars recently joined. Our picture is not here. I also thank my master students. Prathamesh is one of them. So thanks for your support. Without your hard working, I cannot go out and give a talk like this. And I would like to thank, particularly highlight this Pinaz here. Pinaz here is working on a newer algorithm called Zata algorithm. Its full form is Zippy Adaptive Thresholding Algorithm, which is incorporated in Jensen Perimetry. So she is looking at how this test retest variability of a Zata algorithm compared with the Theta algorithm. And soon you will be hearing from our lab. Soon we will be communicating this paper to the journals. So soon you will be hearing it from our labs. So with that, thank you so much. Exactly 45 minutes. I try to keep my talk for 45 minutes. And if you do have questions, please shoot it to me.
Awesome, great. So thank you, Shonraj sir, for that wonderful talk, and taking us through what is available and how you can modify, how you can use it in clinical practice as well, and how it works. Actually, that's the main logic. You must know how it works, the step by step ladder
Yes.
approach, and all of
Yeah.
that, which is something which is
Yes.
really important to understand. When it comes to clinical decision making, I understand that you said that none of them are accurate, or you must always look at the clinical data as well. But as per your expertise, which one is more clinically related? Which one do you think is much more relatable to the clinical findings?
So this again, none of the test algorithms are accurate. Okay, so what you have to do is, when a clinician takes a call, when clinician takes a major call, for example, you put a glaucoma patient in drugs for a long time, and you still think it is progressing, before you take the call of doing a trabeculectomy on them, it's better to repeat the visual fields twice or three times. So if you look at the progression analysis of linear regression analysis we do, or or the GP analysis, what we usually look at is, for past two visits, this location is progressing. For past three visits, this location is progressing. So you need to make sure that for that particular location is progressing for 2 to 3 visits. Then only you take a call. But the problem is this: you really want to take the call before it. So you ideally place the visual fields 6 months apart, right? So you do it one in January, you do it one in July, again you do it again another in another January. So three visual fields apart. And then at three time points, you want to make sure that that particular location is progressing. Okay, then only you take a call about doing the surgery. But actually, that visual field started progressing at this point itself. But you need to wait for 6 more months, or at least a year, to make sure that visual field location is progressing. Then take a call about doing a surgery. Okay, so it becomes very difficult for a clinician because of this variability. They have to do this test multiple times, spaced minimum 3 to 6 months apart, to make sure and then take this very sensitive decision of whether to put them under surgery or not. So you ask me which one is better, we are still trying to figure out. We are still trying to figure out which one is the better. Right now, the best suggestion I can give it to you as a clinician is, if you think a visual field is progressing, do not take any call, do again, ask them to come after 3 months, and then see what is happening there. If you still see that as a progressing, well, again, ask them to come again after 3 months and then do it again. All three times you find it definitely it is progressing, then take a call about doing the surgery or putting them in a different drug. So that's my advice would be.
Yeah, that's right. And I think the ophthalmologist, because usually we get to do a repeat test when the ophthalmologist in the clinical setup or an OPD setting in the hospital tells us. So most of the time, I think students and clinicians are confused. Why do we need to repeat the test? Hence, I asked you this question, and I think you said it very correctly, that it's always look for the progression in terms of looking at 3 months or 6 months data, follow up and check. Don't make a decision when you see that the field is gone in the first visit, right?
Yeah, yeah,
Yeah.
absolutely. Yes.
Great. One question here which popped up, and I think you did cover a little bit as well. What would be the difference between the ZEST and the QUEST testing strategies? If you can just punch in your thoughts here.
Well, it's pretty similar. So I kind of pictorially explain how the ZEST works. I hope you can see my screen again. Do what?
Yeah,
Okay.
yeah. I
No, it's okay. It's okay. No need to. That's fine.
yeah.
See, there's in ZEST, you take a prior probability mass function and you calculate where is the mean of the prior probability mass function, and the mean is usually shown as the stimulus, and then get the response. Instead of you showing the mean of the prior probability mass function, if you show the mode of the prior probability mass function and then do it, that becomes the QUEST test procedure. Okay. So that's the main difference. And again, it follows the similar same thing. Instead of you presenting mean, go with more big maps first.
Awesome. Great. And one question which again popped up is about instructions. I'm just going to modify that.
Yeah.
When you're doing the testing strategies, you have so many now. We
Yes.
talked about ZES, Quest. Is there different instructions to be given to the patient in
Absolutely.
terms of?
Well, see, the instruction matters. Okay, so there is a fantastic study by Michael Wall back in 2000. I'm not sure. I can forward you the paper, but they have given a three different instructions. One is very liberal instructions. One is very conservative instructions, and third one is like you do it whatever you want. Okay, and what turned out to be is your perimetry results becomes very different based upon what type of instructions you are giving it. So if you give more liberal instructions, you are more likely to give more of a false positive responses, whereas if you give more conservative responses, your this thing becomes the false responses becomes less, but as well as your thresholds also comes down a little bit.
Yeah.
Now, so the instructions is always matters, and usually what we say is you give instructions which is not too liberal, what it is not too conservative, and we follow the same set of instructions for everything. And if you really want to look at it, have a look at it in the ocular hypertensive trials or Canadian glaucoma studies, glaucoma intervention studies, CGIS studies. You look at how the instructions are given. They have already printed out those instructions there. So please follow that particular instruction so that for all patients it is always there. But again, these are psychophysical tests. Okay, if the patient is super happy, had a coffee before the perimetry, they might do very well. The patient, you call them at 4 o'clock in the evening, ask them to do a perimetry, again they're going to give you crap results. And if you see something like a crap result, again you are going to ask the patient to come again in the next day morning and then do it. So perimetry becomes really, really tough. It's a challenging task. People take it for granted. Oh, one perimetry done, but it's not like that. So you have to wait to get really accurate results. And if you think you are not getting the patient is not responding properly, please modify the instructions and then ask them to do it again. Instead of you waiting for the whole test to complete, ask them to bring back, redo the instructions, cancel the test, and then do it again. And still, if you are doing it, they are doing it crap, ask them to come next day, ask them to have a cup of coffee, ask them to come back and then do it. That's the only way.
That's right. Yeah. So make sure that the test results are reliable before you make any decision. Again, coming back to the baseline point, what we have been telling since the beginning, right? One question with asking about the normative data. So since we have these different test strategies, if I may put it that way, and the types of perimetry tests, does the normative data vary, or is the whole pool of the data which is there and the system just manipulates it?
Big question, isn't it? We don't know the answer to it. Okay, so we really don't know what is the number of normative data that is there in CETA, to be honest. And we think it is 156 normal persons data, and we think there is few data sets from Asian population as well, Asian and Indian populations as well. But what is there is the proprietary right, so we don't know that. So that's a big question. You can answer it by your own. You collect your own normal visual fields data and then normal Western field data, and then you build your own probabilities and you ask them to Western counterparts to build their own probability maps and then test it on your glaucoma population and see how these probability maps are differentiating from Western and Indian population. So that's a study. You guys can do it.
Yeah, it opens up areas for research. And this is something probably a bit out of the talk, but I thought let's just take it to see if there is any inputs you have on this. In terms of the licensure criteria, there is an Easternman field test which is done globally, but we don't have it in some countries. Any thoughts or anything which you're aware of this?
No, I don't think so. I don't think we have a visual field criteria in an Indian license. There is a visual acuity criteria for sure. The visual field criteria is not there, and the Eastern field test, which tests 120 degrees, just your static supra-threshold strategy, which is not there and which is much needed in Indian government as well, right? So No, it's not there. I think it is there in many of the European countries and UK, but in India, no.
It's not been there. Yeah. Great. Okay, let's just take one question. Again, this is related to, I think, your forte in terms of algorithms. So I thought just put it up. Do you think we need to, get working into algorithms that identify test location, which are useful for follow-ups and which are less variable for clinical use in terms of,
Already, you should answer this, Vasant. Vasant is, I know Vasant is working on similar along the lines. But you asked me what is my take is on. Um, Well, let me put it this way. So do you want me, let me read it again. So you want to identify test locations that are useful for follow-up or identify locations with abnormal locations as in the different base system of yours. I would go with the first one, which are more useful for follow-up. Let's say any locations which are less than 20 decibels is crap, right? So we don't want to test them, right? They are variable. But what really we want to test them is where exactly the progression is happening. So if you ask me, we really want to place the locations at the edges of the scotoma. It is not just the depth, how it goes, the scotoma goes in depth, but more than that, how the scotoma is growing in space is probably more important than looking the how the scotoma goes down in depth. So in that case, probably the arrest is probably a much better approach than doing a defect based sampling. So again, sorry about the audience. The arrest is an approach which looks at how the scotoma is growing in size rather than looking at how the scotoma is going down in depth. So probably if you ask me, Vasant, I would say that arrest is probably a much better approach compared to the defect-based sampling approach.
Awesome. Great, great. So I think with that, thank you so much, Dr. Shonraj, for a wonderful session and also, answering and sharing your thoughts and expertise onto the questions which have been shared by the audience today. Thank you so much.
Thank you. Thanks a lot. See ya.
We do have session planned next weekend. Until then, take care, be safe, and I hope to see you next week. Bye-bye.
Bye.
Bye. Thank you, Dr. Shonraj.